So let's start with the monoclonal antibodies, because obviously they've been the big news of 2015, 2016, and I think obviously daratumumab is a breakthrough drug, appropriately designated so by the FDA back in 2013, and it's proven its mettle. Dara's, transformative. I think elotuzumab is equally transformative in a different context, whereas daratumumab's a powerful drug in its own right as a monotherapy. Elotuzumab needs a partner, be it proteasome inhibition, interestingly enough, or more typically immunomodulation. So I think we're seeing that with both ELO and DARA, real promise. DARA clearly as a monotherapy, and when you add stuff to it, it really goes into overdrive. ELO, the same story, with interestingly a somewhat different tolerability profile, which makes ELO kind of very interesting as a maintenance drug and as a drug for, say, the older or frailer patient. That's not in any way underestimate DARA. DARA is a game changer in that regard. So both antibodies are great. We also heard about isatuximab, or isatuximab. The pronunciation kind of varies a little bit. I'm sure we'll get comfortable with it. But isatuximab is a CD38 targeting drug, which has really interesting qualitative differences to DARA, it would seem, preclinically. Whether this translates clinically, we don't know, but certainly the data so far is very, very promising. They both seem to be very active. One may have some advantages, the isatuximab, from the standpoint of infusion time and so on, that may be actually very beneficial to patients in the future. So I think there's some really interesting new antibodies in a nutshell, Charlie. And then as we think about the new proteasome inhibitors, ixazomib obviously is fantastic as a new oral agent that's well tolerated and ideal perhaps in an older, frailer patient, but also of course could be very active and appropriate in a younger patient too. The carfilzomib data continue to look very strong with unprecedented duration of responses achieved, and I think that all bodes well, particularly in combination. And then in the immunomodulatory space, lenalidomide is just clearly a phenomenal agent. Pomalidomide, equally sort of impressive and a great salvage strategy when lenalidomide runs out of gas. And I think in the same context, we're looking at the HDAC story. We're seeing panobinostat show really interesting results in a variety of settings, but very excitingly, we have a more selective inhibitor, so-called AC1215 or now AC241, which is showing real promise as well with less toxicity. So, I think there's a whole array of new drugs coming through the pipeline. And I think we were able to touch on them in the session today to illustrate how continuous therapy matters, how best responses to induction matter, how we can be thoughtful now about how we use transplant. And I would simply say, Charlie, when it comes to transplant, probably the best way of thinking about it right now is outside of the US, it's clearly a standard of care. In the US, it is a standard of care, but is it the standard of care? And I think that's a key question. I personally would believe or advocate for one size does not fit all. And the reality now, with our newer drugs, both in induction and in salvage, critically, that patients have choices. And I think our trials are telling us that, recognizing that the French interim analysis suggests no difference in overall survival whether you have a transplant early or you keep it in reserve. There is a progression-free survival advantage, but that's in the context of a maintenance strategy that stops after 1 year. And a key message we heard today from Dr. Palumbo was that clearly maintenance matters, and his maintenance goes until progression. And there he showed very convincingly the curves showing that benefit. So I was very impressed by that aspect of Antonio's presentation.